And this is House Healthcare. And this morning we have in the Department of Mental Health to discuss their budget recommends. So welcome, Commissioner.
Thank you.
You can take it away.
Great. For the record, Emily Hawes, Commissioner for the Department of Mental Health. And I have with me today
Samantha Sweet, Deputy Commissioner of the Department of Mental Health.
Good morning, I'm Shannon Thompson, the Financial Director for the Department of Mental Health.
So I'm going to start off with a brief reset overview of the department, who we are, what we do, and then we'll get into initiatives and ups and downs. So from the Department of Mental Health mission is to promote and improve the mental health of Vermonters. In 2020, DMH went through a very robust strategic planning process and developed Vision 2030. And so DMH still operates under this vision. It is still very relevant to the things that we're seeing and doing across the mental health space. And so the four key components for Vision 2030 was improving the client experience, improving the health of populations, reducing the cost of care, and improving the healthcare provider experience. As an overview of our system and the folks that we provide oversight and designation to, we contract and oversee 10 designated agencies, 2 specialized service agencies, and 6 designated hospitals. We operate the Vermont Psychiatric Care Hospital, which is a 25-bed facility for adults who are under the care and custody of the commissioner in Berlin. And then we also operate River Valley Therapeutic Residence, and that's in Essex, and is a 16-bed residential facility for adults who are under the care and custody of the commissioner. As a department, we have around 230 staff at both of the facilities. We have around 69 central office staff, which provides all the administrative support, business office, legal services. We collaborate with all of the Vermont hospitals. We hold a contract for forensic psychiatry, also psychiatric consultation within the primary care space, law enforcement, courts. We partner closely with the Vermont Care Partners, Federation of Families for Children's Mental Health, Center for Health and Learning, and so on. From a system capacity perspective, across our designated agencies, there are around 38 adult crisis beds. We have 18 youth crisis beds and then 42 adult intensive residential. From a hospital level of care, which is your highest level of care in the system, we have 57 level 1 beds. So a level 1 bed is the term the state of Vermont uses to define a hospital bed where an individual requires additional resources in order to appropriately care for them during their acute stay. Those additional resources could be court-ordered medication, but it could also be the staffing levels to support that individual in their care. We also have across the system in Vermont 128 adult beds that we call general units or non-level 1 units. They have a different staffing ratio. They typically do not include court-ordered medication and the legal services that a level 1 unit might. And then the children and youth system, which has 30 beds, which are currently all located at the Brattleboro Retreat. And then through historic legislation, there's a current certificate of need with the Green Mountain Care Board for adolescent inpatient beds at Southwestern Vermont Medical Center, and that is not reflected in here because the CON hasn't been completed yet. We also have peer service agencies, which have adult crisis beds. There's 2 beds in the peer service agencies and then 5 intensive residential beds. And as I mentioned earlier, our state secure residential, which is the River Valley Therapeutic Residence.
Leslie, did you have a question?
I do. Someone submitted a bill, one of my colleagues, to add 2 more adult crisis beds. Or have you come across that? Have you heard about that?
I have heard about
Yeah,
that.
I'm just wondering what you think about adding that. Is that a good thing or maybe not needed or what you, I mean, and I know I'm sort of leaning at you, so,
That's okay.
yeah.
My first response would be I'd need to know a little bit more about what the details of the bill are.
Yeah,
And of course, we're open to having as many tools in our toolbox as possible. So I would just need to know a little bit more
they're pretty
about.
much doubling this, you know, that kind of model is helpful,
Mhm,
a lot, but when they're full, they're full.
mhm,
And
yeah.
2 more, would 2 more make a difference? And so that's what I'm just wondering.
I'm going to transition us into a highlight of our new initiatives, which this first one is a continuation of previous initiatives. So continuing to build on the CCBHC framework. And the CCBHC model is a national model for community mental health and substance use services. And it requires an agency to have crisis mental health services, targeted case management, outpatient mental health and substance use, screening assessment. Some highlights with this model also are the integration of peer supports or persons with lived experience, as well as a formal relationship with providing services for veterans. And then increasing the primary care screening and monitoring for individuals receiving services. Our goal with the CCBHC model is to have an integrated and sustainably financed model for care delivery that ensures access, including crisis response and medication-assisted therapy or treatment. That's for individuals with opioid use disorder and alcohol use disorder. Meets stringent criteria from a timeline of access, quality reporting, staffing, and coordinating with other social services. And then also receiving flexible funding to support the real costs of expanding service to fully meet the need for care in communities.
Questions?
A highlight of what's currently happening with the CCBHC work. There's 5 designated agencies across the system who applied for and received federal planning grants. $1 million a year for 4 years to prepare to become a CCBHC. There is an immense amount of work that happens in the background in order for a clinic to meet the CCBHC requirements. And so those agencies are Claire Martin Center, Healthcare and Rehabilitation Services of Vermont, HCRS, the Howard Center, Northeast Kingdom Human Services, and Rutland Mental Health. About 2 years now, the DMH received a federal planning grant to assist moving clinics into the CCBHC model. And so what you see at the bottom of this screen is a timeline of what that federal planning grant looks like. Through last year's legislative session, we worked with this committee to finalize our path forward for certification for 2 agencies. We applied with the federal government to become a demonstration state, which allows us to have an enhanced federal rate for the services coming under the CCBHC model. We applied for that. We were awarded to a designation state, and we have two agencies that will start preliminary, they're in preliminary certification from a state lens with a start date of July 1st, 2020.
Leslie?
I'm just curious, we said there's a lot of work going on in the background and I'm
Mhm.
curious to what that means. $1 million, I'm hoping goes a long way. So a long way towards what?
So it is really taking a look at all of the books that go into a particular agency moving towards certification. So there's costing and reporting related to staffing models, the delivery of care under particular licenses, administrative costs. There are also lifts from data and shifting data reporting to come into line with the particular quality measures. So some EHR work happening, electronic health record work happening to make sure that all of that information is being fed appropriately, being tracked appropriately. And not all agencies provide co-occurring care. So it's also making sure that the agencies working towards certification are able to deliver co-occurring care. So there's treatment, training, and all sorts of sort of the nuts and bolts that are, it's a pretty dramatic shift in how an agency delivers care. And so it hits about every single layer within an organization.
So does that mean new staff or is it all within the staff that's there?
It's potentially a mixture of both.
This is a question, I don't know if you can answer it or not. I know that Central Vermont is not one of these. And we all know that the hospital has got rid of their mental health unit. Is Central Vermont trying to get away from mental health services?
Are you indicating like Central Vermont Medical Center?
Both this medical center and the Central Vermont Mental Health Agency.
So Washington County Mental Health has a planning grant. Do they have a planning grant? No, they don't. Washington County I would say no. Washington County Mental Health is quite committed to delivering mental health and substance use care in Central Vermont. They are working towards becoming into certification for CCBHCs. They're not in our next round. They just acquired the substance use provider here in Central Vermont, and so they just have a little bit of growing in that area. But from my perspective, Washington County Mental Health is quite committed to serving their community.
I don't dispute that at all.
Yeah,
I'm a great supporter of it.
yeah.
But I'm having trouble with staff. Something's going on.
Yeah, staffing, we're going to talk a little bit more about staffing as we get through this presentation. In general, healthcare staffing is in a really challenging position, and that's across all of healthcare. From a DMH lens, we want to support our agencies in optimizing licensure. So making sure that folks who are working at the top of their license are billing at that license. We want to make sure that we don't have overlapping resources that require two people to maybe do one person's work. And we'll get to that when we talk a little bit about two cuts that the department is proposing. Because we have an interesting dance happening right now, in that the state has grant funded several resources into our communities. And those grant funds were really valuable at the time because there weren't other opportunities to streamline and respond to communities. As we've seen opportunities like Enhanced Mobile Crisis or CCBHCs that provide a mechanism to provide those services, we no longer have to look for grants to provide those services, and we can shift those staff into other models but we don't want staff, from an efficiency of care delivery, we don't want one staff working under a grant and one staff working under a payment model and sort of doing the same thing. We would like to have the one staff work under the payment model, and the community not feel a impact from that shift. Because it's really just the system is evolving and should evolve. And so we don't need as many straight dollars. We can bill services that we didn't used to be able to bill for. That was a long-winded response to that, but we'll talk.
I'm just
a little bit
worried
more about
that-
that.
you know, the outside, I used to be very close to the agency, but there's a new director there now and so on. But what I see happening is a hospital providing services and then not providing services. I'm thinking, okay, Washington County Mental Health, it's a huge agency. You know, maybe they'll figure out a way to help, you know, provide those services. And now I see that they're not in this round anyway.
Yeah. It might be worth having Washington County or Central Vermont come in and talk a little bit about the coordination with those shifts at Central Vermont Medical Center. We are looking at perhaps enhancing urgent care resources in the area from a mental health urgent care perspective, and those teams are working closely together, but it may benefit this committee to have those groups come in and talk a little bit about that.
Yeah, I know the family physicians, the medical home people, they've got a mental health person in there now. Okay, thank you.
Yeah, you're welcome. What do you?
Yes, it seems funny to me that an agency that's basically in charge, or not in charge, but oversees the designated agencies, has to go through a CON. Could you explain the amount of paperwork and funding and personnel that you have to deal with that issue?
Sure.
And then I'll have
Yeah.
a question.
The CON that I was referring to is related to an inpatient unit within the hospital, and so that's outside of the designated agency. That was a legislatively approved project from, I think, session maybe 23. And so that CON, the threshold for that project is required to go through the CON process, as the CON process is currently defined. And so the lift with that lives with Southwestern Medical Center. They're the ones who are putting forth that paperwork to the Green Mountain Care Board. We oversee that. We've answered questions that the Green Mountain Care Board has had about the overall system and wait times. We're sort of we're waiting for them to make a decision of whether or not to move forward.
So you do provide some sort of assistance?
Some sort, but the big lift sits
the
with the
hospital.
hospital that's applying for the unit.
Okay. And then the other question is the CCBHCs. What happens when your grant funding runs out? What preparations have you made, just in your budget down the road?
Yeah. So our grant the $1 million grant will run out. I think we actually are under an extension until the end of March, and that will run out. We have two initiatives that currently receive enhanced federal match dollars. I'll talk specifically about the CCBHC model, where the two agencies are going live this coming July. We'll be able to draw down that enhanced rate until 2028, I believe, 29. I always get it confused with the IMD rules. In that time where agencies are able to draw down the enhanced rate, we'll need to put into play opportunities to continue delivering care in that way. And so my guess is that's either comes back through some legislative, but also we hope that some of the dollars that are spent outside of what can be drawn down in a daily or monthly rate, that we can shift those dollars back into that system. And so it's not large asks back to the legislature, but we're able to kind of drop some historic programs and evolve those into where the system is heading in order to better serve those communities. It's a delicate dance. And we're fully aware of that.
And I realize that we're not in appropriations right now, but just couldn't help but ask.
Yeah, it's a valid question. We also want our agency and our system to thrive and be successful, and the same that we want for our communities. And so we also have to exploit as much Medicaid and federal dollars that we can bring into our system.
Well, interesting times.
Yes.
Is the enhanced rate of CCBHCs under our waiver?
No, it is not under our waiver. It is outside of our current waiver. And it is the same enhanced rate as the CHIP rate, which Shannon can talk a little bit more about what the details are of that. But we were awarded as a demonstration state. And so that project is outside of what our current waiver experiences. Going to move us into our next initiative and turn this section over to Deputy Sweet.
Hi, good morning. So I am going to talk about our initiative with Alternative to Emergency Departments. You'll also hear them called Mental Health Urgent Cares. That's what a lot of our community members call them. So we found that there's a critical need to have, just like in the medical world, there's urgent cares, we need a mental health urgent care. And so to deflect people from going to the emergency room, where we know oftentimes the emergency room is not a therapeutic or a supportive place to be for a lot of our clientele, we now have alternative to emergency departments. We know that our mental health urgent cares provide very therapeutic and trauma-informed care, and which oftentimes, because of how hectic emergency rooms can be, we don't see that same level of care happening there. We also work with a lot of our urgent cares in our communities, partner with various folks that are in their community, whether it's the health centers or local law enforcement, or with schools, and so that they know that there is an urgent care in their community where folks can go. And we found that this is just helping our system to stabilize and to make it a much more robust system to be able to support someone through their crisis and then refer them to their local agency for further services. Yeah.
Some of these settings already in place?
Yes, I'm gonna go through that next.
Okay.
So, this slide's super tiny. Can't even see that with my glasses on. Thank you. Sorry, I'm gonna take your space up.
You're fine, you're fine. I don't.
Oh, I appreciate that. So this is a list of our current mental health urgent cares or alternatives to emergency departments. We have, as you'll see through this list, some are really focused on youth and some are focused on adults. And then we have one or two that are focused on the whole age span. Where we do want to go is seeing that facilities are serving the whole age span, so you don't have to go outside your region to receive this support. So we have Interlude, which is at CSAC, which is in Middlebury, and that we also have the open office hours, and I'll speak to that in a minute. We have Front Porch, which is in Northeast Kingdom, and that is facilitated by Northeast Kingdom Human Services, and that supports the whole age span. Access Hub is in Washington County, and that is run by Washington County Mental Health, and that's for adults only right now. We have mental health urgent care at the Howard Center, which is the partnership that I spoke about a minute ago, where it's a partnership with Howard Center, UVM Medical Center, Pathways for the Peer Services, and Community Health Center in Burlington. So that is a nice model that we see there, and that is, again, serving adults only right now. Psychiatric urgent care for kids is at UCS, which is Bennington County, and they are, of course, serving youth right now, ages 3 to 18. We have what's called EPIC, which is Emergent Psychiatric Intervention for Children in Lamoille County, run by Lamoille County Mental Health, and that's for youth. And then we have one in HCRS area, which is Windham, Windsor County, and that's serving youth. So you'll see that the times are listed that they are open. We would also like to see these times expand into evening hours, some weekend hours. What's holding these facilities from doing that is staffing. And so they are trying to open more hours as they hire more staff.
Leslie?
Can you explain what referral only means in HCRS in the program?
Yeah, so this is not, HCRS is unique in this, in that they don't have a physical location. And so what they do is provide the staff to go and do in-home services. So that's how they're handling the youth and working with the youth in their family system. And so that's why it's referral only. It's not a walk-in. You can't walk into an actual building, but it's more you call and they come to you
What's the time frame for that?
for them to respond.
Yeah,
Mm,
you call,
yeah.
they come to you days, weeks, whatever.
Oh, it's urgent care. So I'm hoping, I will say, I'm hoping that is within the hour, but I don't have that. But I
I'd
will.
be curious,
Yeah,
yeah,
we
that's
can get that for
obviously
you.
my district, so.
And
well,
we
not obvious, but
do,
for me.
we do have a bunch of data and we will get that for you.
Thank you.
Yeah.
Topper, and then I have a question.
This staffing issue.
Mhm.
What incentives are being offered to people to work those other hours?
Yeah.
And what's happening in terms of wages?
Yeah, so I'll speak to it and then maybe Shannon can also speak to it a little bit, or maybe Commissioner Hawes fill in any gaps. What we see is that it's nights and weekends are the toughest to fill. We don't see a lot of folks wanting to work those hours. And so we have been able to give, there is shift differential in each one of these facilities. So more for second, third shift, weekend hours, things like that. We also know, and I'll turn this over to Shannon about the funding. Is that later on?
Well, I think we have some slides.
Oh, okay.
Emily, if you.
Yeah, because we had done those overview of several one-time funding initiatives that we have supported our system with. But to add on to Deputy Sweet's comments about agencies do hiring bonuses, I'd say across healthcare, evening and overnight shifts are the most challenging. There's also working in a 12-hour shift model versus 8-hour shift model. If you need less staff to staff a facility when you're on a 12-hour shift model versus an 8-hour shift model. And staff typically like it because you're only working half of the days in a pay period instead of the 10 days during a pay period, they're working 7. And so they're able to have some flexibility on the work that they're doing. So there's some scheduling benefits that we've talked through different agencies. But it's really, we can provide someone, we don't tell agencies how to, what they pay their staff. And we don't tell them how to manage their hiring bonuses But we do provide some opportunities and some problem solving around that.
It's a workout.
It's worked in some cases, but it certainly hasn't solved the staffing challenge. We still see vacancies across the system, although it's less vacancies. But there's still, I think, around 600 or 800 vacancies across the system. And so, but that's better than it was. And so our conversation has shifted in a way where we're examining programs that might be very similar, where there's staffing gaps, and can you combine those programs to deliver that care? And like I was talking about earlier, shifting away from grant funded if we don't need a grant funding or general fund program, because that was because that was implemented maybe a decade or so ago, and billing opportunities have shifted since then. So it's those efficiency of staff conversations that we're having, and then also making sure we're optimizing the licensure of the individuals who are working. So a master's level clinician should be doing master's level clinician required work, and the administrative work should be done by administrative staff. If an individual is a master's level clinician, but they want to be a case manager, they can't, the expectation shouldn't be that they're getting paid as a master's level clinician, because that's not the service that they're delivering. And so it's just having those conversations and supporting our system with creative thinking around those things.
The staff, I'm sorry, did you?
Go
did
ahead.
you I wanted a clarification around, you said 600 to 800 staff vacancies.
Yeah.
Do we have a breakdown of administrative versus clinical?
We don't, do we?
Yeah, we do.
Oh, we do.
We
Okay.
do. We added that into our provider agreement measure last year, so we could know how many are administrative staff versus the clinical staff. And so we do have those numbers.
Okay.
Not today, but we will.
That was what I was.
Oh, was that?
No,
It's the impact of this staffing problem. You know how you go in the doctor and they get the little faces of, where is your pain level? Well, I'm looking at where is the crisis level?
yeah.
And with that many people, that many positions open, we'd like to know.
Yeah.
So I'm wondering if you do any correlation with 988 data, when do most of the calls come in
Yes.
compared to availability?
Correct.
So can you speak to that?
Yes, we have a slide that we
Oh,
can
okay.
share.
Sorry.
Okay.
Oh, sorry.
We did pull that because we had talked a little bit about that when we were here for our overview. So that was my decision to kind of pull those.
I'm
but
just looking at
knew
the
we only had
hours.
90
I can't help
minutes.
but wonder, looking at the hours, like what we're
Mhm.
missing in the
Yeah.
off hours. and
Yeah.
Could we find any data? And maybe this is fine. And that's sort of the question.
It is, and Nicole will pull up the slide, but as she's doing that, what we found is most calls into 988 are coming during the day and evening hours and tapering off dramatically at 9 p.m. Okay, so not a whole lot of calls are coming in during the overnight hours. And then we have a breakdown of what days most calls come in, which surprisingly is
Monday and Tuesday.
yep. Monday and Tuesday. So, well, that's for emergency
Oh,
department
emergency,
friends.
yeah.
Most people go to the emergency room on Mondays and Tuesdays. And between 3 and 6 p.m. So that's why we tried to look at the alternative to ED and mirror those times to make sure that the alternative to ED programs were open during those 3 to 6 p.m. as we see that most people go to the emergency room during that time. For 988 trends, most calls are received about 9 p.m.
But it's peaking at 7 to 10.
Yep.
So that worries me.
So
Right, because there's a
Yeah.
gap.
yeah, there is a gap a little bit. So, but what we do have is enhanced mobile crisis. And so that is 24/7 statewide, and where it's a 2-person team, and one of those two can be a paraprofessional and oftentimes is a peer. And so that can be, even though our mental health urgent cares might not be open till 10 p.m. right now, we do have mental health enhanced mobile crisis, sorry, that can respond wherever someone is experiencing that crisis.
I'm sorry to divert you. I see you have 32 slides, so.
And 988 can dispatch those
Yes.
mobile crisis teams 24/7.
And just an FYI, you are welcome to be with us as long as you
Oh,
would
dear.
be with us today. If you want to throw up an slide, so you're on no time schedule for today, so take all the time you need.
Thank you.
Oh, Woody?
Yes, I'm getting back to your new initiatives, the alternatives to emergency departments.
Yeah.
Do you have numbers of patients for each of these facilities?
We do.
And whether they're able to be treated at these facilities or whether they have to move on to something else?
We do have those numbers where it's limited data because most of them just opened in the last 3 to 6 months. But we do have a number of how many people were seen at the mental health urgent cares and then how many actually had to be referred to the emergency department for further assessment for inpatient hospitalization.
It would
And
be
we can
interesting to
get
have
that,
that
yeah.
on that slide.
Yeah. We should, absolutely, and we can share that data with you. We were trying to limit how much
Right,
data we were
okay.
throwing at you, and
That's
so,
good.
so yeah.
I think from our perspective as well, we're looking at that data to help determine what urgent care approaches are supporting communities best. Because there are a variety of different mental alternatives to ED approaches that the
And what's
state
effective
currently
and what
has.
isn't.
Yep. Yeah. And our goal is to have a regional approach, which is the slide that's up now, in that mental health urgent care is available to folks within a reasonable driving distance.
So yeah, like Commissioner Hawes just shared, this is a heat map, and what we tried to do is try to take a regional approach. And so we want to see how much time it takes regionally for someone to get to a mental health urgent care versus the local emergency department. Because if you have to drive double the time to get to mental health urgent care than it takes to get to emergency department, the emergency department's going to become the default because it's just so much closer. And we know transportation, it can be an issue at times. So this is just a heat map that shows where our urgent cares are located. The state of Vermont in the green is showing the population. And so where there's the most population area, we tried to really look at making sure we had a mental health urgent care.
Can't help but notice southern part of the state is pretty blank.
And we did not put HCRS's urgent care on the blue map because they don't have a physical location. They go out. And so there probably should be a little mental health urgent care icon in that area. And we also want to see it expand and have a facility. So
And I
there's
thought it would
work
be a
to
good
do.
idea because then when you look at it, it's like, yeah, it's there, it's a different model, but
Yeah.
it's.
Yeah. So this is a slide that shares the hospital wait times. The picture on the left is adults and the picture on the right is youth. And you can see the average wait time. It's kind of a messy slide, but it's one that hopefully will show you during COVID times when we were kind of at our peak, seeing the most people in emergency rooms. Those are the highest numbers and the highest amount of hours someone waited. We also experienced a number of inpatient hospital beds were closed due to COVID-related, staffing-related. And so that was the longest time. We have come back down to pre-COVID numbers and hours. We still have a handful of beds throughout the system that are still closed that we are hopefully working on to open those up. But again, that's due to staffing and patient numbers and, but as you can see, we're almost identical to where they, or better off than pre-COVID.
I'm actually kind of surprised we're still doing this. You know, I was here when we first
Yeah.
implemented it.
And we
during
want
COVID.
to continue, sorry that I cut you off, but what we want to do is continue watching this while we bring on mental health urgent cares, because we want to see these numbers go down even further. So we're going to continue this for a little bit longer so we can see, does have having more mental health urgent cares, does it impact these numbers?
I think there's also opportunities to explore and target other initiatives with
Mhm.
this information. So if we see that, you know, folks are waiting because the right resource isn't available in the state. I know that the Department of Aging and Independent Living hasn't been in here yet, I think, to talk about eye care, which is their new contract in Bennington with a assisted living that can take folks who have complex needs from a psychiatric perspective, but also involved in the criminal justice, and then also need a nursing home level of care. And you looking at the data that contributes to somebody's weight helps us define and implement other resources like the urgent cares, the eye care down in Bennington, but also other things like what transportation changes need to be made because somebody could wait because transport isn't available. And so there are a lot of complexities to something that shouldn't be as complex as it is. And so it's still important to us. Hopefully it can go away. That's my hope.
One day.
One day.
One day.
I realize that, you know, their mandate, emergency departments are required to see anyone that walks through their doors.
Mhm.
Do we ever foresee getting to a place where there are mental health urgent care centers for both youth and adults located close by to emergency departments, where emergency departments can actually take people and refer to
Mm.
that type of facility? You know, again, to the premise of right place, right time,
Yeah.
right service.
Yes. I would say that there are some regulation challenges to that from a hospital regulation lens. I think the UVMMC Howard Center urgent care is a nice reflection of that. They couldn't have it too close to their emergency department because it impacts the broader hospital system. So at the federal level, there are some challenges to that. Our hope is that, you know, folks don't necessarily need an emergency room visit or to be walked over unless there's like truly an acute emergency services need. And so I think that would be the goal, is to make that as streamlined as possible, as close and integrated as possible. There are some barriers that we don't have control over with that.
Is law enforcement bringing people to, I'm thinking about, you know, the front porch, is it?
Mhm.
Are law enforcement bypassing now the emergency department and bringing to that facility?
They can.
They can.
I'm not sure how much it's happening yet. It's still relatively new. So I think we're trying to gather the data and figure out what's prohibiting law enforcement from going directly to mental health urgent care versus emergency room. And so it's something we're looking at, and we don't have the data yet, but they can bring someone to urgent cares. What we've seen in other states is that other states have mental health urgent cares where law enforcement can come. And the goal of the mental health urgent care is to get the law enforcement to be in and out within less than 5 minutes. And so ultimately, we'd love to get there. I think we just have more work to do and more time to develop this.
There's some significant culture shifts. People are in a habit of going to an emergency room. And so, focusing efforts on communication strategies across primary care, across law enforcement, allowing opportunities for the urgent cares to continue to stabilize and get into their own rhythm. That's what we would hope, is that we can make that culture shift happen where it's not, oh, I'm experiencing a crisis. The only answer to that crisis is getting dropped off at an emergency room.
Do you think our increased use of embedded mental health with embedding mental health with law enforcement, do you think that that will have an effect on that?
I think the state currently has a couple of approaches happening with folks who are embedded with law enforcement. We have the program that happens across the Vermont State Police. And then there are also some smaller communities that have embedded workers with local police. And I do think that there's room at the table for all folks. And we also know that data shows that the goal is to not have law enforcement responding to individuals experiencing a mental health and substance use crisis. But that if they do need to respond, that they have the skills and the supports that they need to do so. That decreases the impact on the individual in crisis. But there's a culture shift there too. Sometimes it's just easy to go to the emergency room.
Thank you. What I'm seeing or hearing, correct me if I'm wrong, and I'm only going to talk about Washington County. I see the express care, kind of like primary care on the Barry Montpelier Road. And I see these other private express care coming up. And I see this initiative, the mental health urgent care. And then I see Washington County Mental Health in that area.
Mhm.
And I'm wondering, how are you coming together? I mean, are you planning together? Are you know, all of these are good initiatives. I'm
Yeah.
100% behind these kinds of things, but I'm just wondering if one hand knows what the other one's doing.
Yeah. I think for the most part around services for mental health and substance use, there's good collaboration happening. I think it's important to keep in mind that, our priority are individuals who are eligible for Medicaid. And we have a lot of folks who are also, who also have private insurance or who are uninsured, which are also a priority for us. But there are options in your private insurance sector that are different than in your Medicaid sector. And so it is important for all of those resources to be talking together and streamlining. So it's easy for someone, whatever insurance they have, to get to the resource that best suits them.
I just hope we're not stepping on each other's feet, that's all.
You and me both. Yeah, that doesn't serve anybody well. And it's all around the same type of skilled staff. And so
Staffing problem.
that's right. And so when we start working through our budget, we'll talk a little bit about those shifts that we're making in order to streamline that.
Thank you.
Yes, thank you. Okay. How we doing?
We're doing great.
Great. So we're gonna move us into our budget for FY 26, and I will turn it over to Shannon Thompson. Do you need this?
Yes.
I want to bring up a bunch of computers.
I have a question, which I could save to the end, which is fine. I just want a chance to get it on the table.
Okay, what? Did you wanna
It has nothing to do
put
with
the
the
question on the table, or did you wanna let me know that you have a question?
I want to let you know I have a question I want to get on the table.
Okay, all right.
Good morning, everyone. Again, I'm Shannon Thompson, the Financial Director for the Department of Mental Health. This here is a summary of our overall budget and the different fund sources that we have. It also gives you a kind of a peek into some of the budget requests that we have and some of the initiatives and the budget savings or downs we have. Our overall budget is currently, we're requesting $334,818,318. That is made up of a number of different fund sources. Our biggest fund source is Medicaid Global Commitment. And that is $235 million, about 70% of our budget. We also have some Medicaid investment funds that you'll also see called Global Commitment, about $52 million there. We have some general fund, about $31.5 million of general fund. A little tiny piece of special fund, and that is billings at the hospital for the most part, and the therapeutic community residents. We also have a very small portion of interdepartmental transfers, $1.3 million there. And then federal funds, we're requesting $12,900,000 of federal funds in our budget. Some of the things that you'll see in our budget ups are our salary and fringe increases, funding for patient representatives and training, stipends and trainings, internal service fund changes, a budget pressure for our private non-medical facilities for children, and additional federal authority, as well as interdepartmental spending authority. We've talked to you a little bit about the budget initiatives for CCBHC and alternatives for the emergency department. And then we have a couple of budget downs that our commissioner will talk to you about later. And so that some of those are moving funds from for our integrating family services budget for the children, moving those back to DCF. I have to have Steve about that, threw me off. Howard Center Community Outreach, and then embedded clinicians in pediatric practice. So our FY26 proposed expenses, this is just going to give you an idea of the programs that we have and the funding that goes along with those programs. The big blue one here is, I'll start with the adult services. That is our CRT program that you'll hear us talk about a little bit later as being changed now to serious mental illness. It's peer supports, emergency services for adults, and that's about $109.5 million. We have a small portion of the pie, $5.9 million of inpatient, and that's Rutland Regional, a little bit of other ancillary charges for hospitals. We also have our mobile crisis response, so that's $9.3 million. We have crisis services, alternatives to the emergency department, and 988, that's about $6.4 million. The Vermont Psychiatric Care Hospital, that is about $34.5 million of our budget. The River Valley Therapeutic Community Residents is $9.7 million. Our children's community services, that's our case rate, additional peer services and federal grants, $61.9 million. Our Success Beyond 6 program at $72 million. That's for children in school services. PNMI, spoke about that a little bit earlier, private non-medical institutions for children. That's about $10 million there. And then administration of about $14.5 million. Any questions there? We'll jump right into the ups and downs, and I'll give everybody an opportunity to pull out their spreadsheets. We all set? So the first thing I'll talk about is the Department of Mental Health currently has one appropriation for the entire department that is under B 314. We are requesting to split our budget into two distinct appropriations. The first one under 314 will be the Department of Mental Health Central Office, which holds all the central office staff as well as our programs for children and adults. And then the second appropriation is for our facilities, the Vermont Psychiatric Care Hospital and the Therapeutic Community Residence. So those two facilities, we have broken those out for transparency purposes, so you see visibly how much we're spending on those two facilities.
Clarifying question.
Yes,
So where's 314 on this? I'm lost.
314 is your first appropriation. It is the 31500700000 at the top here for the Department of Mental Health.
Stand up if you could. I'm sorry.
Sure. This is currently our overall budget.
Okay.
But we are splitting it into two sections. So you're going to see here this big reduction. You're going to see the offset down on the next page. Could you just, please, thank you. So this is 31500100000. That's inpatient facilities. So that's the second piece of the appropriation. And there's the exact offset.
But that's still 315. And you were talking about 314, and that's what I was not lost about.
Leslie, look at your handout.
I have my handout.
See the gray bar over here? The first page, it says 314.
Yes, it's probably not up there. It's right here. This one.
Got it.
There you go.
Appreciate it. Because I saw 315 underneath, so I was looking for the same
Yes.
thing.
Oh, my apologies.
No
Yes.
worries, you know, these are your words. Yeah, how you think.
Yes. Okay. So the first item on our ups and downs is the movement of the personal services portion of the budget down into the facilities. So we have to reduce mental health central office. That's why there's a negative $38,681,170. The next group here, I'll group all of these next several where it says salary and fringe, health, retirement. That is all our salary and fringe increases due to steps and COLA cost of living increases. The combined total of those is a gross of $1,039,213. The next item is our internal service fund, workers' compensation. That is a slight reduction. You'll see a similar thing in the inpatient facilities side. We have other personal services on the next line. That is simply because we received 4 positions for mobile crisis in the FY24 budget throughout fiscal year 25. In fiscal year 25, we had 2 open positions that had not been RFR'd yet, so we had to have them on the other personal services line because it was not in the position section.
RFR?
Request for.
That's the formal, yeah, that's the formal
Classification.
process for the position to show up.
For our request for
Reclassification.
Reclassification.
thank you. Acronyms.
Whoops, I'm sorry.
I just said acronyms.
Sorry, yes. So we have since RFR'd all of the positions. So now that money is being removed from that line item in the budget, and it's up in the upper section with the salary and fringe pieces. So that's what that is. The next item is the Act 264 board stipends and parent representatives. That is a request for funds for to pay for parent representative and stipends due to the mandate under Act 264. I don't know, if you want to speak to that at all?
Yeah, can you remind us what that is?
Yes, were you taking kids today?
Go, it doesn't
I
matter,
can.
either way. Go ahead.
Sure. So sorry, I was in the middle of a drink when you asked that. So related to the X 264 process provides an opportunity for parents to attend and represent on behalf of their children. And so this provides an opportunity for a stipend so that they could be reimbursed for the time spent advocating. And so this is a shift as we began that money started coming through the department. Used to be mental health block grant funded. And so this is a shift away from the mental health block grant for those parent representations.
The next item is a movement of our operating expenses, again, out of central office, into the inpatient facilities. A portion of our funding needs to be moved down into that section. So this is just $3 million, $3,306,000 is being moved down into the facilities section. The next item is internal service fund charges. So that is your fee for space, insurance, general liability, the vision accounting system, the Agency of Digital Services allocations, human resources, and all of those various internal service funds. The next line item is a technical correction to our operating funds. It is a zero net. It is a zero net request in a movement of funding between fund sources. So just for the years, our fund sources change based on federal grants that we might have or numbers of staff that we have in central office. So the funding, the fund sources change a little bit. So this is just kind of correcting the fund sources that we had, giving us a little bit more general fund and a little bit more under global commitment. So that's that line item. The next line item is Agency of Digital Services end user increase funding there. That's an increase of 40,829. That's just increased costs for the staff, the IT staff that we utilize throughout the year from Agency of Digital Services. Okay, so the next item here is a transfer from the Vermont Department of Health for, oops, I'm sorry, I'm on the wrong line item. This one is a transfer to DCF for services under the Northwest Counseling and Support Services, NCSS, for developmental services waiver children. That funding came over in about 2015 for our Integrating Family Services program. And that program is going back to DCF. So we are just transferring the funds from DMH to DCF. Similarly, we are transferring funds again for NCSS for the Children's Integrated Services portion of the IFS program, the Integrating Family Services program under the mental health case rate. That program is also going back to DCF. So the funds as well. The next line item is another transfer back to DCF of $739,000 for the Parent-Child Center. Again, that was an IFS program at DMH, and we are transferring those funds back to DCF because they hold the Parent-Child Centers.
Just that there shouldn't be any From a community perspective and as someone receiving services perspective, there shouldn't be any impact on those folks. It's just a transition of funds back to DCF. The program stays the same. So there shouldn't be an impact at the service delivery level.
Woody, did you have a question?
I did, but it's fine. Fine.
And for the record, for my committee members, if I don't see you, flag me because I can't see without my glasses on. So I'm bad.
Okay, so this next one is a transfer from the Vermont Department of Health for substance use services for our CCBHC, Certified Community Based Integrated Health Centers. The acronym is actually Certified Community Behavioral Health, but we name it Certified Community Based Integrated Health Centers. That's funding from VDH to come over for the two organizations who will become CCBHCs.
Those,
Go
yeah, I
ahead.
was just gonna highlight that those are directly related to the efforts to create a more integrated and co-occurring system of care. So those are dollars to support both services delivered from a mental health and substance use perspective for those two agencies. Currently, the Vermont Department of Health oversees the Division of Substance Use.
Ellen?
Just confusing for me. You're transferring all this money back to the TCF. What's the reason?
Go
Let
ahead.
me take that one. Yeah, so as we're moving into the CCBHC world, we're looking at services being provided within CCBHC. The IFS was only 2 regions. It was NCSS in Franklin County and then CSAC and Middlebury. And so they are DCF is going to be providing the services for the DCF unit.
And like
And
St.
so-
Albans.
Mhm.
Okay.
Yeah.
No, just, thanks.
Yeah.
The next line item here is our CCBHC adjustment for Clara Martin and Rutland Mental Health Services. Those are the two agencies that will become CCBHCs on July 1 of 25. It's a request of $2,643,779. The next line item is our federal authority request.
Mhm.
Go ahead.
Can you explain that rate adjustment a little bit more? Why they're getting that?
Yes, so I think Commissioner Hawes explained that CCBHCs pay cost for services. So this was a projection of what the additional cost is going to be for those two regions to provide the full array of CCBHC services. It is at an enhanced rate, so it's not an actual general fund ask. It is actually going to be a slight savings, general fund savings, because of the enhanced federal participation.
So this is just pulling down from Medicaid dollars.
Correct.
So this is really only a portion of general fund. That 2 million is a large part, or whatever the rate is. 0.52
Well-
federal funds.
It's so the enhanced federal participation rate is the CHIP rate, which is 71% federal money. So that's why it's so basically what we're doing is we're taking the current case rates. And that is also going to have a savings, a general fund savings associated with it. We're going to combine it with this additional money. And the overall bucket of funding for CCBHC will be a general fund savings. Because of the.
That's helpful. Thank you.
And this rate, this is just for a rate adjustment. This is not part of the grant for $1 million that was received for implementation.
That was
Okay.
a planning grant. Yep.
Okay.
Thank you.
The next line item is a request for additional federal authority. So throughout the year, the last few years, we have gotten additional federal funds through block grants. We've had increases in our some of our other children's grants. In that process, when we receive a grant, we go through a process to request the ability to use those funds and enter into the agreement with the feds. And we request that through the JFO.
JFC.
Once we,
JFC.
Joint Fiscal Committee, thank you.
Yes.
Thank you.
No approval.
And so we receive permission to spend the funds, but we don't always have enough federal authority in our budget in order to actually use those funds. So this is just a request for additional federal authority to match our need.
No, go ahead.
So that. Wait, I'm trying to track over.
It's $1,128,903.
Is that total amount,
This one here.
block grant dollars?
It's a combination. It's a lot of additional block grant, but it's a combination of different grants that we have.
Another grant that's in there besides the block grant is the pediatric mental health care access, which is the psychiatry consult.
Yeah, big fan of that one.
Yeah.
So the next line item here is similarly, we are requesting interdepartmental transfer spending authority. There, we are experiencing some collaborations with departments that require additional spending authority. So we need that authority in our spend. That's $472,219.
Leslie?
My question that I wanted to get on the table, and it could be now or later, whatever makes sense in terms of your presentation, was I know that you were charged about responsible gaming and working on that. So now I see you have a line item, and I went, maybe you're going ahead. I went to your website, about responsible gaming.
Mhm.
I don't do it now because you'd be in charge with this flow. But I just wanted to understand that piece. So if you want to do it now, that's cool, but
Sure.
whatever.
Sure, happy to do that. That's the $500,000 interdepartmental transfer line item.
So currently, under responsible gaming, and the Department of Mental Health set this up from the ground up. We currently work to support 24/7 helpline support, peer support, media campaigns, and then also supporting the training and development of clinicians across the system to support folks with responsible gaming or problem.
So, I'm sorry, no, finish, let's let. Finish.
Thank you. I'm just thinking about the way it's modeled, if I understand this correctly, is people have to come to you. And I'm wondering if there's outreach to people, if you notice bankruptcies or, is there a way to identify people before, in a way, they identify themselves that they need help? So that's what I'm wondering about.
Yes, so this slide shows the current work that's happening from a media perspective, utilizing social media opportunities, iHeartRadio, so streaming platforms, podcasts, 3 15-second public service announcement. We just started doing gas station toppers, which is a visual opportunity for folks to have access to resources. And it still is a very new program. And so we continue to gather information. And this is what's currently happening as far as supporting our communities and knowing what resources are available to them.
So it says like 113,000 impressions. Is that the word? I can't read it. Sorry.
Yes, impressions.
What's an impression?
5,000. Oh, those are the hits that are going through the website.
On your DMH website?
The problem gaming
Yeah,
website.
that page. Yeah, because as I say, I looked at that page. That sounds like a lot. Is that a lot?
I think it's
Or, I mean, I
a,
don't know how we measure a lot.
yeah, I mean, I think given that it started, from the ground up, it's a good sign that people are accessing resources that are available to them, or at least learning about them.
It's about the population of Vermont. So, when we think about 500, I mean, they're probably not unique, but I get that it seems like worrisome to me that this is what we're seeing right at the beginning of the program. And where do they go? And I'm not, as I say, I'm not saying you should do it necessarily, but I think it's a worry.
I reframe that a little bit. It could also be that, folks are really trying to educate themselves on, what resources are available. Maybe they're considering, getting into responsible gaming. And so, it could also be, used as a way to, educate self before there's an issue.
Could be.
Yeah, I just think we don't know what
Yeah,
this
I
number
think
is,
that's
so
something-
we're
Wow.
reading into it a little bit. And
Mhm.
I would say part of the training that Commissioner Hall has talked about is with the therapists at the DAs or therapists in private practice. It was a training held so that they can identify and treat anyone that's walking through their door that may have problem gambling.
But I guess there's no way to identify bankruptcies or something. That seems way too, I don't imagine that, but that's what I worry about, of course.
Yeah.
Families being affected in
Sure.
this very dark way. So I don't know how to think about that. What's our responsibility? We did approve it.
That's a.
Bad vote on my part, I'm gonna say.
Alan, did you?
You answered a lot of it, but if a person calls support group, what's the protocol after that? Do you have them call back or do you call them? Or if somebody's got a concern that they have a gambling problem?
Go ahead.
Ticket. So, someone calls into the hotline, they get a live person, they can be referred, so they support them right there on the hotline and refer. And so who do they need? Are they willing to go to a group? Are they willing to go to independent or individual therapy? So it's helping in the moment and referring to ongoing.
So there's follow-up.
services.
Yep.
Mhm.
Okay.
Yes.
Okay.
I'm sorry, I didn't see you back there.
No, I just whispered it, because I can't sit there because it hurts.
Brian has a question.
Yeah, is there any evidence that it's helping public health, the gambling? People making money off of it, money going back into the community and helping families?
I think that the problem gambling initiative is in its infant, stages, and there's still more information to be gleaned from that.
Yeah, to follow up on that, I think that there's what, before it was legal, people were doing it anyway. So have we prevented harm by doing this? And that's sort of my question, because people are moving theoretically from the shadows to the open system, and I wanted to understand if we have improved, like, outcomes that way.
We're happy to have the team of folks who oversee our problem gambling program in collaboration with liquor and lottery to come in and talk more specifically about those details, if that's helpful.
Yeah, as I recall, Department of Liquor and Lottery said that they're losing money right now because there are a number of winners. But I would just remind everyone that the house always wins.
Over time.
Sometimes the Senate wins.
Yes.
All right, are we moving on from gaming?
Yeah, thank you for that interlude there. I don't know if you, well, we have time or just to go on with it, but I think it's a word. Well, for me, it's a word.
Okay. Noted.
So noted.
So the next line item is for private non-medical institutions, PNMI. It's a caseload and utilization increase. We're requesting $822,304. So basically, we are seeing an increase in utilization and cost. and Deputy Commissioner Sweet can give you some more information.
So it's exactly what Shannon just shared. We are coming out of the pandemic, and what we're seeing is that more youth are struggling, right? And so we know that, and we see more kids in need of residential treatment right now. And so we're seeing an increase in utilization, and the PNMI rates have also increased. So it's twofold for us right now.
Anyone have any questions? I have one question, which is a follow-up, because we talked about this through the BAA. And you sent us a wonderful graph. Thank you very much, as follow-up testimony, which can be found on our website under BAA or Commissioner Hawes' name. I was curious when I was looking at it, though, because it breaks down out of state, in state, which was sort of what our questions were aligning. And I realize it's a tiny little number, but it seems that anything that goes through Dale is all out of state. So what, may I ask, are we referring to youth, adolescents with developmental disabilities? And there was no orange on anything in state. Do we not have any placement facility or any?
For folks who
Potential.
are under the developmental disabilities.
Yeah.
plans.
So if you, of course, would need to have a Department of
Yes.
Disability and Aging and Independent Living come in and speak specifically. But if their primary diagnosis that they are experiencing a crisis and need residential treatment is related to a mental health, then absolutely that they use the residential facilities within Vermont. And so our children's care management team helps with finding placement for those. If their primary diagnosis is not related to mental health, then I think most of Dale or Department for Disability and Aging and Independent Living needs to refer out of state, because I don't believe that they have any in-state facilities.
What if they have co-occurring diagnoses?
Yeah, that happens all the time. So like I said, if their primary problem for the residential care needs is mental health related, then yes. Oftentimes they have co-occurring. And so we'll see that a lot. And we actually hear a lot from our community partners that they're having to change their own treatment, the treatment that they're providing within the residential because of the co-occurring that they're seeing more and more. And so it's no longer just youth with mental health. They're seeing youth with mental health and developmental disability or an intellectual disability. So, but if the primary diagnosis is not mental health related, I do think that Dale needs to refer out of state.
But we do have the capacity within the state of Vermont to care for children who may require residential care that have both
Yes.
a developmental disability as well as a co-occurring mental health.
I will say, just to clarify a little bit, as long as the primary problem is a mental health related one, then yes, it can be supported by Department of Mental Health and mental health funding to the residentials.
Thank you. And thank you for the follow-up testimony from last time. I'm sorry, Brian, did you have a question?
Yeah, I've heard from at least one constituent that when their child needed residential treatment, that the family actually was put in a position where like the expense was burdensome on them, and even with Medicaid backup, there were barriers to access because of the way. And I'm still trying to understand with them exactly what the sequence of barriers in place, but essentially they've been put in a position where their child has to be out of state a lot,
Mhm.
and it costs a massive amount of money,
Mhm.
whether they're paying for it or the state.
Mhm.
And they're saying it's because there's a lack of options in the state, and the primary issue is mental. So I'm just curious, like, if you could say more about like what that, without knowing the details, does that didn't spark anything in you about like an explanation of like why that might be the case for them?
I can start and please fill in.
Yeah.
Without knowing the details, it's
Yeah.
hard to speak to this,
Yeah.
but if Medicaid is involved, then that is the funding stream that pays for the residential. So I don't know why a family would experience a financial hardship from placing
If they have, their primary insurance is Blue Cross Blue Shield.
that.
And they have an extremely high deductible, and then and so they were saying like when the Medicaid kicks in, it doesn't even kick in, or it doesn't, they're trying to explain to me the complication here.
I think there is some known complexities
Mhm.
when the private market interacts with the Medicaid market. So I think in general, though, there are state resources, there are out-of-state resources. We also did a lot of work bringing a PRTF, which stands for a psychiatric residential treatment facility for youth, which is currently in a contract negotiation. But that's another level of care that the state hasn't had access to. And youth who meet that level of care all had to go out of state because we didn't offer that here. And so we are in the process of expanding access to residential care for youth through that PRTF designation, which is a designation that equates a higher level of nursing care need for an individual in a residential program.
Are those the additional beds at Brattleboro or the additional facility at?
Those are residential beds at Brattleboro. Those are currently in contract conversations with the retreat that came out of last year's legislative session.
When do we anticipate that they will be opening?
We would like them yesterday. And so I would say we are on the home stretch of the contract negotiations. It's looking good. There's meetings happening frequently to get that over the crossing line.
Do we expect to see some savings somewhere in the next? Oh, we'll get.
There's
Go ahead.
savings
Okay.
associated with that line item here. We did have some assumptions in here for savings. Otherwise, the line item of $822,000 or $6,000 would have been higher. So it's contemplated in there.
Okay.
Would it be okay if we talk more off, like out of the committee about the specifics of that case so that I can help them understand more? And also perhaps it might help, then I can come back to the committee with some more like specifics of what the barriers are so that we could help them possibly.
Yeah, we're happy to be at the
Yeah.
table to talk through whatever barriers that we need to look at in order to get folks care, knowing that there might be some barriers out of all of our control.
The federal stuff.
With private insurance.
Or with private insurance,
Of course.
yeah.
Or just lack of things in the system, lack of like specialized but we'll talk about it. I just don't want to take too much
Yes.
time now.
We're
I
happy to help problem solve
Okay.
and chances are the family has been engaged
I
in
think so.
conversations with the department, so we can figure.
Okay.
that out.
Oh, Topper?
We talked about children. How about 22 and above?
For residential care? Speak to that?
Yeah, sure. So, is there anything specific for the 22 and above you're thinking about with that question? We don't have necessarily specialized residential programs. Well, I take that back. We have, one intensive residential down in the HCRS area that, is geared towards serving folks who are young adults early in their in their experience with the adult mental health system. But we, individuals who are, 18 to 22 access the adult inpatient system. They're typically accessing the adult residential system as well. So is there anything particular about that age group that you're looking for information on?
Well, I'm looking for if there's anything new. I know about the models and all that kind of stuff.
Like new facilities?
Yeah, new ideas.
Um,
We have people that are in the intellectually disabled or parents that are aging out. They can't take care of their kids anymore.
yes.
And their main a problem is mental health, it's autism. And
Yeah,
so
so.
I'm just asking, is there any new initiatives that are floating around?
Yeah, I would encourage you to have the Department of Aging and Independent Living, the autism services sit under that department.
Right. The next line item is another one for private non-medical institutions, the PMIs. This is related to their inflationary increase due to the rate setting process. That's $309,448. Then we have a request to convert some funding that you gave to Pathways a couple of years ago. This was the $390,000 that was for Pathways for their Bennington region, and it was given as general fund. So now that they have that program established, they are able to pull down Medicaid. So this is converting that to support some of their other programs. Converting it to Medicaid from general fund.
Do you remember what we gave it to them for a couple years ago?
Yeah, to expand services in Bennington up to 30.
30.
Yeah, 30 individuals.
You
Okay,
mean inpatient, when you said 30 individuals, you mean
Caseload,
caseload?
working in the community with individuals.
I can't believe it, but I actually remember that.
Yeah, and so it took around a year or so, and they've been providing services in the Bennington area. This is a positive.
okay, so it's being used for what it was originally intended.
We're converting it so that we can support some of the other programs. And then the next two line items, I will let our commissioners speak to.
Yep. These next two items, with the first one being the Howard Center Community Outreach. This is a program that is currently grant funded. And so I want to make sure that it's me that's introducing this because it's a cut or a perceived cut. And I want to talk a little bit about the philosophy of why we're doing this for this area. So the community outreach is a local community support worker that's grant funded and works in the neighboring communities in Chittenden County, such as Winooski. And so this is one of the programs that we talked a little bit about that historically made sense to grant fund out a position that does this community-based work. We would like to pull that position into the enhanced mobile crisis response so that that individual is able to respond from the lens of a person-centered mobile crisis approach versus sitting in an office waiting for the sort of crisis to come to them via phone, managing calls via phone. Data for this particular position with the community outreach grant does show that anywhere from, 57 to 66% are phone calls, with 40% being, a community response. This is an opportunity for us to kind of push our system a little bit with, evolving. And having an enhanced mobile crisis team available in the community. So they don't need to be sitting in an office to get deployed. They can be out where where folks are.
Can you clarify that for me? Because I think I lost the thread on that.
Sure.
So 66% of their contacts that they're making were from a call that came over the phone from someone within the community
Correct.
versus what's the other 30?
Yeah, versus interacting like out in the community with somebody experiencing a need or a crisis.
Okay,
And so what we would like to support our system in evolving to is letting crisis calls go to 988, where most are resolved via phone, and then having our 988 teams dispatch a mobile crisis.
are they going out to this 66%?
Not necessarily, no. They're resolved over the phone.
They're definitely resolved over the phone. Or they're possibly resolved over the phone.
They are resolved over the phone from the data that we have.
So 66% of all the contacts that are made are resolved over the phone, and there's no contact made with that individual or.
It depends. I don't think they're checking per person. Like somebody may call multiple times. So I wouldn't say that it's a direct one-to-one. But when we look at, say, having a master's level clinician answering that phone, 66% of the time, those calls could go to 988. We have a resource that can answer the call. And then if that individual or if an individual needs a response in the community, then the enhanced mobile crisis team can be deployed. How we have set up our enhanced mobile crisis program is that it is not designated agency specific. And so agencies can overlap in their community responses. It doesn't have to just be a Howard Center. We also allow for a person with lived experience who is also responding to someone. And then I think shifting the idea that you need to be in an office in order to be deployed is, I think, a valuable shift here as well. If you know that there's a busy area in your downtown and you are there, you don't need to be deployed from an office to support the folks in the community. Anything that you want to add to
The
that?
only thing I would add is that enhanced mobile crisis is 24/7. So these positions are time limited, so it may be a 40-hour position across a few different towns. And so this, with enhanced mobile crisis, we're actually giving each town more hours, more responses, the ability to respond.
Did you have a question?
Yes. Are there any staff shortages in the mobile crisis program?
Yes.
What was your question?
There's staff shortages everywhere.
In the mobile crisis team?
Shortages? Is that what you said? Okay, sorry.
There are staff vacancies across, there are staff vacancies across emergency services teams. What we've asked is there to be some fluidity across an emergency services team. And so somebody's job may not necessarily just be screening for inpatient hospitalization via voluntary or involuntary basis. So we don't necessarily want only a mental health, a mobile response team, and like these two people only do this work, but we do want some flexibility across our first responder system to allow for some flexibility in order to meet people where they are when they need it.
Daisy, or would you like to wait, Sylvia? I'm asking you. I know you had a couple of questions, so
I
Did
do
you
have a
want-
couple questions. I think you should, but I have a lot of them, so you should let other folks go first.
okay.
Maybe they'll answer
That's-
some of them.
I have two.
Okay.
One is, how does the Howard Center feel about this? And two is, how is this actually operationalized? Because you say it's gonna be folded in, but what does that exactly mean? Like, is there gonna be the same staff and the savings comes from some administrative expense? Or is there gonna be cutting of a supervisor because you can fold people under one person? Or like how, those are my two questions.
Yes, and those are great questions.
Yeah.
Do you
I
want,
can
since
take
you
it.
had those
Yeah,
conversations?
so I've had multiple conversations with the Howard Center prior to this, so that we could start having this conversation, before it got,
To this point.
Yeah, exactly. And so my understanding is that a lot of these folks, these staff that were in these positions were already helping the enhanced mobile crisis to respond. So they were being pulled into situations so the two-person could respond. And so that was when I first brought this Howard Center to say, hey, they said we were having very similar thoughts to begin with anyway, so this isn't shocking to us. So and so the thought is to bring in those staff to be part of the the enhanced mobile crisis team.
Where do the savings come from then?
That we no longer need to grant out general fund or grant dollars in order to support something that's actually billable.
Because once it's integrated into mobile crisis, you can bill Medicaid or whoever.
Yep.
Okay, now I understand it more.
Yeah,
Okay.
Yeah.
So it's not really a cut, it's a shift of revenue source.
right.
Okay.
Yeah, it looks like a cut.
Yeah.
And that we want to be very transparent about that, but it also connects with our, longer term goals of evolving our system a little bit and taking an opportunity to analyze what came into play in our system before billable opportunities were developed.
Leslie, did you have a question?
I'm good.
Okay. Daisy?
This is a really confusing cut to me. And I hope nothing I say, because I'm confused, and I've met with so many municipal leaders in Winooski about it.
Yeah.
I hope nothing I say because of my frustrations about losing the program offends any of you, because I have such deep respect for your leadership and the choices you make. But one, this program impacts 6 or 8 municipalities? 8?
I think it is 7.
7.
Yeah.
But you're not just shifting the cost to mobile crisis, you're shifting this cost to municipalities. Winooski Public Safety presented their budget in our city council recently, and it includes the cut. You're passing it on to local taxpayers, is what you're doing. So you're asking us to pay what the state is cutting if we want to continue community outreach. And what I've heard from all of my local leaders is this program is invaluable because they don't want to go through 988. And I recognize and totally appreciate that that is our goal, to centralize and create that efficiency, but we are not ready. You said evolving the program, and I love that. And I love that your vision is to do that. But I'm hearing loud and clear from that municipality and others that we are not ready. And I think that there's also a payment problem with this. I don't know if it's true. Maybe you can help me understand if the community outreach requires a diagnosis for someone to sit and talk with someone on the street. I mean, my municipal folks say that they can sit down, these workers, and have a conversation with someone in crisis on the sidewalk and get them over the hurdle that they're currently in. And more often than not, they have done it before with the same exact person. And that's why this program works. They don't need to do any sort of assessment with them so that they can bill Medicaid. And that's why they love this program. It's fast and it's consistent. And that's not the case with mobile crisis. They have to call 988. 988 has to figure out the dispatch thing. It might be hours before someone responds, and it's definitely going to be a different person. And there's a staffing issue right now. which, you know, maybe shifting this funding over there might help that. Maybe the nudge might help build up mobile crisis. We all want to see it, but we're not ready.
I have a couple of thoughts. What, from a municipality lens, does being ready look like?
I think it looks like improving the access. Like, I think we all understand that sitting with someone who's in crisis and trying to do some sort of screening, it's not realistic. You don't want to do intake on a sidewalk with someone who's holding a weapon or whatever, you know, like that's not the time.
Yeah.
You know that more than anybody in here, Emily. And I just, you know, it's a small line item. And I think, you know, a nudge toward supporting mobile crisis is totally welcomed. But I think putting this on the backs of municipalities is not something that I would support.
Yeah. I think, from our perspective, we're not putting it on the backs of municipalities. I know that municipalities are thinking of putting this into their budget. We see this as an opportunity to increase access for folks. And looking at the data for what the towns are experiencing and sorting through the feelings, because none of us want folks to go without being served. And I think we share a mutual respect for our communities in that way. Our goal would be that municipalities don't feel or experience the shift that we're making. And that if, say, Johnny is the current community outreach person, that's just who's funding that position. But Johnny can still be an enhanced mobile crisis responder and still be out in communities working with individuals when they need it. And from a departmental lens, when you see that most are done over the phone, over half, that means that there might not, to us, that there might not be as much in person, in the moment crisis de-escalation happening in those real time. But that's what people remember, right? People remember those real time interactions with their community members. And we have to look at, is that happening once a week? Or is that happening once an hour, and shift our response time in order to meet that need? With enhanced mobile crisis, responses within an hour.
I also, one last thing, I question whether, you know, the reason that people are back in the office is because of the administrative burden and the workforce shortage. Like, people do more than one job. Thank you.
And just to follow up, because this affects my community as well.
Absolutely.
And community leaders in Essex have talked about what an invaluable resource this is. My concern is more on a systemic level of funneling everything through 988 and using that as a response to everything. Because the community outreach position, I struggle to use the word crisis all the time. And when we label everything as a crisis, which might be some of the reason why they're not going out, because it's not a crisis. I know people in my community who've used this as a resource, and it's more of a, hey, I'm a little concerned. Is there, you know, some help this individual might need? And when we start turning everything into an emergent response, mobile crisis unit, call 988, aren't we diluting what those systems are meant to be used for. I mean, 988 is a suicide hotline. It's,
I wouldn't say that it's purely for folks, it's for anybody. Whatever their self-defined struggle is, and I don't disagree with you, when we call everything a crisis, or pathologizing crisis, and so I get that. Some of our language is provided to us through the programs that we're operating, and so I get that. Most calls through 988, which is text, and call and chat are resolved in that moment. And so also with a dispatch, that doesn't take away that each agency still has their crisis number. I thought your contact just, I'm sorry. That doesn't take away that each agency doesn't still operate their local emergency services. But we were in a conversation with an agency that identified that, they were really struggling in getting their enhanced mobile crisis out into the community to interact. And I said, well, you have a strip mall that is identified by your municipality as having a lot of folks who seem to be experiencing something. That's where your mobile crisis is for the day. That's where you deploy them instead of to the office to wait for the call. You're deploying that team of folks or whoever's on staff for that day to that strip mall to interact with folks. And so from our perspective, it does serve a very similar opportunity for community members to get supports when and where they need it. But I do understand, it's not lost on me. It is a large culture shift to be looking at this. We are pushing things. I don't think it will ever feel right because it's easy as humans to do work that you don't have to document or do any administrative work to. And then it's also hard to let go of things that folks are tied to and used to. We see that with emergency departments. Folks are used to going to emergency departments to get support. So I hear you.
if you don't mind, I'd like to move on. We still have several things to get through, and I didn't know, do you have a hard stop at all?
What time's your hard stop?
I have a hard stop at 11:30. I have a noon meeting. I cannot.
Okay. Go ahead, because I don't even think we're about 2/3 done, I think.
I think we're just in the tough stuff right now, I think. And so I think the next line item is a very similar approach, which there are two agencies that have of our entire designated agency system, there are two agencies that have an embedded worker at a local pediatric office. And so this is a proposal to decrease funding for those two positions. And shift either those individuals who are working within those positions onto other teams where they can be better utilized. Pause there. I can see there's questions, so I'll pause there.
I can't see there are questions, but I'm alerted that there are.
Yeah.
Did you have a question?
Yes. Where is the psychiatric office at is it the?
It's a pediatric office.
Pediatric office, where is
Sure.
that located?
Yeah, it's a primary care office in Milton. And then the Northeast Kingdom, sorry, I'm connecting you
Yes.
just now. The Northeast Kingdom Human Services office is in,
I don't know where that,
Well,
they
it's in-
haven't had someone
in
in that
Derby?
position for
it might be in
over 4
Derby.
years.
It's
Or in
been,
New-
yeah, it's
one
been
in New-
vacant for 4 years.
Yeah.
So they don't even have it.
Yeah,
No.
can you speak to that? That's what I'm looking at.
I'm sorry, let's let Woody finish his
Okay,
question.
sorry.
Well, you're just taking a total of 538,000. Where does the 269,000 show up in your budget for you know, the pediatric office or the Howard Center or whatever.
So I can explain those amounts if that would be helpful. The total, you're right, is 538,822. The reason that you're seeing half of it as general fund and half of it as federal funds is because it's Medicaid admin funding, which is a 50-50 split between general fund and federal funds. That's all that is.
Well, I think this situation is the same as what we were previously talking about. And I wonder if we were to do something with the budget request or when we submit our budget request, is this something that we could work on?
I'll put it on our tracker.
Would you be offended by that? I'm putting you on the spot. I'm sorry.
That's okay. It's a very, I think one of the goals that we have here is that there's some consistency and equity to services statewide. And so we have two agencies that have a special program that none of the other agencies have access to or have. And agencies are able to serve their communities. We do have some data related to the Howard Center. And so that is what's on right now. Howard Center receives the largest amount of that whole dollar amount. So they split that up between the position at the Milton Pediatric Office. And then some dollars go to First Call, which is their crisis team. And so when you look at the data that we're showing, and we don't have data for Northeast Kingdom,
Well, I
it's
was
been
just gonna
vacant.
ask you
Yes,
about it.
we don't have any because
How
it's been
many-
vacant
how
for 4
many,
years.
Young children should have been seen that haven't been.
That's a really valid question.
You said the position's been vacant for 4 years in the Northeast Kingdom?
That's correct.
That means that they're unable to hire a person?
That I don't
It's-
know if they're unable or
It's not
haven't,
uncommon, I will
yeah.
in defense, it's not uncommon, lack of housing, lack of individuals that really that want to move there. You know, it's a combination of other things.
There's a need.
There is,
Yeah.
yes,
Yeah.
absolutely.
Well, what we don't know is that need being adequately and appropriately served through other resources in the community.
I will say that the Northeast Kingdom Human Services and its leadership does a very good job in meeting the needs of the community. That said, more can always be done.
Yeah,
May I ask really quickly, you just have Milton Pediatrics. Is that Mousetrap or is that Timberlane?
oh, I don't know the
It's a
difference.
UVM practice.
It's
So
a
that
UVM.
helps answer that.
So it is,
UVMMC.
so it's a UVM MC University Pediatrics, I think, most of their, and it's their Milton office. Okay, thank you. Leslie, did you have a question?
I do. We had a conversation the other day about sort of the perfect primary care model. It included embedded social worker and embedded pharmacy. I know we're not talking about that, but what I worry about is that if you take it away, it'll never come back. And once you eliminate the position, there's no way we can ever, it's hard to get things back. And I worry about that because we're taking something away that really shouldn't be. Even though we couldn't fill it, maybe we will next week. We don't know.
Okay.
And so I'm with you.
From a perspective of a position that is filled with Milton, the number of folks that they're seeing a quarter is 11. And so a quarter is 3 months. There's a 40-hour work week, and they're seeing 11 individuals.
Week or the whole quarter?
Either way, whole quarter.
But they're for a full-time job. That's low.
Correct.
That's like a third of anyone else's caseload.
This is why we're having this.
Yeah, okay. I'm just trying to validate that. I'm hearing that. All right.
So could I ask?
Yes, go ahead.
So is there a way to combine, or is there a way to be more creative? Than not totally eliminate access if there's not
Yes.
enough service? How do you
Yes,
can
there
you
is
do
a way.
both?
Yes.
Yes, and. is
Yes,
what-
and.
Yeah,
Without having somebody sitting there for 40 hours a week. And I don't want to come off as being dismissive of the work. From a body, a master's level clinician perspective, that's a lot of time, perhaps getting, in your downtime, your administrative time, connecting somebody, with insurance. But from the data, most folks already have insurance. And so, and we have other resources developed in the state to help folks connect with Medicaid and get enrolled in Medicaid. And I don't know if that's a function of a designated agency in a pediatric office to do. The other component of this is opportunities through CCBHC grants at Howard Center. There's also opportunities through Blueprint for primary care supports. We're having to look specifically at what DMH provides and oversees, and then develop an efficiency and an equity of access for folks.
And may I ask, are both these practices, are they both in the blueprint?
That is a good question. I don't think so, but we can find out.
Or whether or not they're receiving community health team funding through blueprint?
We can find that out.
And Leslie, did you want to finish your question and then?
yeah, I think that I'd like to, like, I hear what you're saying is that you think that these services could be provided else, in a different way perhaps. But I would be curious and want to see a plan for that before we eliminate the position. It seems like a little backwards to me, because as I say, once you're gone, you're gone. Getting something back is really hard. So I know 11.
What does that plan look like to you? Because in our plan, that plan is part of the work that we're doing with CCBHCs, 988, and mental health urgent care, and enhanced mobile crisis.
So you're feeling that that whole array is going to meet the needs of this community's needs?
Correct.
So that would be what I would want to see sort of a little more formally, I guess.
When you come up with this plan, you've had reasons, okay?
Yes.
So you did the one in Milton as far as the numbers. If there hasn't been a position for 4 years in the Northeast Kingdom, what research did you come up with? Those patients have had to be seen by someone else. So what was the research to come to that decision up there? Just, it wasn't filled?
Was it filled?
Wasn't filled.
Oh, that wasn't filled. Yep. Do you want to take the first stab and then?
I can, and tell me if I'm not answering your question the way I understand it. So, because the position in the Northeast Kingdom had not been filled for 4 years, and the data that we received from the Howard Center on these positions was really low. And there's an expectation with these positions of, the goal is for them to see youth and get them connected to Medicaid or health insurance of some sort. The data is showing us that almost 100% have health insurance already. So, so through looking at all those things, it was decided that, and what Commissioner Hawes spoke about earlier around CCBHCs and all these other services that we have added to the system, we don't need these 2 independent positions. We are trying to look at the system as a whole to say what makes sense, what can we continue to do, where do we put our funds and our energy into looking at a statewide approach and not doing these small grants to different positions that could help shifting those staff over to these larger initiatives that are serving more individuals in Vermont makes sense to us.
When you say that looking at the ones that were treated or what have you, that had health insurance, these are not Medicaid patients, correct?
I don't know the breakdown of Medicaid, but the positions were created to help youth access Medicaid. So if they didn't have health insurance, could they be connected to Medicaid? And so what we're seeing is that 100%, almost 100% have insurance. So
But you
whether
don't
that's
know whether it's
Medicaid
Medicaid
or
or
private
private.
insurance.
If I don't know what the numbers are, you
Yeah.
don't either. But if you've got health insurance, you're gonna go where your child will be treated and helped.
Yes.
Medicaid, as you may know, and you probably do, that's a big population in the
Mhm.
Northeast Kingdom.
Yeah. Yes.
So are those people getting the assistance and the help that they need? And I don't think you have the data. I don't.
We don't. Yeah, we
No.
don't have the data, but we're.
That's concerning.
Mhm.
And
Yeah.
I think there's some other interactions with the broader mental health system that youth have outside of primary care. So we also know that, youth are interacting with the mental health system in schools. So there's opportunities to be identified, through the school system as well.
But you don't know whether they're interacting in the schools.
We don't know if the same person that gets service at a pediatric office is necessarily the same person interacting at the, and then if they have, say, Blue Cross Blue Shield, we don't. What we do know is that when we have conversations with a designated agency and we talk about what their community needs, we had discussed for the past several years that this position is open and where are those youth potentially, hitting the system in a different way.
Well, like I
And that's,
said,
yeah,
Kelsey Stavitt and his team.
Yes.
have done a very good job.
they've done a great job. And are those youth who are, they've also done really well with enhanced global crisis response with the Front Porch
Mhm.
program. And those are really wonderful opportunities for youth to get connected outside of primary care.
Yes,
But
thank you.
yes. Daisy, did you have a question?
I did. When you were showing this slide, I realized that the community outreach was also Howard Center Community Outreach. And I'm wondering if there's other community outreach grants in the state other than Howard Center Community Outreach.
Not that we fund.
There's no other grants for community outreach.
No.
Oh, Washington County. Block grant.
Oh, it's
you're right.
block grant. Washington County,
Small, it's $40,000.
40,000, yeah.
Very small.
And that's, have you thought about transitioning that one to mobile crisis as well?
Yes.
And I'd like to thank Deputy Commissioner for reminding us, and I'm so glad that you're looking at like the whole system of care that we have and looking for duplicative services. And, yeah, I appreciate you reminding us of that.
Yes,
Great work, Emily.
Yeah.
Thank you.
okay, thank you.
So we have a few more items.
Oh,
to-
I'm ready to go.
So the next one here is the shared living providers,
Oh,
no
yes.
longer being eligible for Medicaid. This is shifting funding for 4 designated agencies that covers 8 separate individuals under the shared living providers, shifting it from Medicaid to general fund. And the reason for that is because our waiver covering the services to individuals with serious mental illness, we refer to it as community rehabilitation and treatment, CRT. Those services are moving out of the waivers, the 1115 waiver and into the state plan amendment as services. In doing that, this particular service doesn't qualify for Medicaid. So we're shifting it to general fund so that we can continue those services for the individuals currently in the program. We will not be extending to other individuals. We're maintaining the individuals who are currently in this program.
And that is a shift related to habilitative versus rehabilitative services. And we are no longer authorized to provide services in a habilitative manner. That doesn't impact the Department of Aging and Independent Living. This is specific for individuals who had received and have received and will receive CRT services. So moving those services over to the state plan amendment. Yes. Stacey?
I warned your team that I had a lot of questions about this.
Yeah.
I know there are only a small number of folks in the state on CRT or that get those services, right? And correct.
2,900?
Yeah.
Oh.
It was probably about 2,400.
I thought it was far fewer. So then my concern is bigger.
That gets CRT. Mhm.
Correct me if I'm wrong, these are folks who are receiving like intensive services. They have need for very specialized care, intensive treatments. So I think my concern is that we run a risk when you're transitioning them to a different eligibility program. So can you talk a bit about what the eligibility is going to be? I understand it's going to have something to do with their diagnosis. Are they going to have to be re-diagnosed? I know that you're doing the ANSA. Can you talk a little bit about that? Because I think it's a significant risk, because if people don't meet your new criteria for this, where are those folks going to end up in our system? And do those providers have the ability to meet their needs?
Yeah. I'm gonna do a quick,
Yep.
and then you can go, and I know you have a hard 11:30. I'd like to preface the conversation with two things. One is the philosophy that an adult can come in and out of the services they want and need based on their need, versus here you are with this diagnosis and there's an array of services available. You can pick and choose what you want, but you're sort of just in this package of services for a while. And so what this shift allows us to do is not participate in conflict-free case management, but B, also provides a framework for adults to choose the services they want to participate in based on their need through the ANSA. And so I'll turn it over to Sam, and she can talk a little bit about the FMI eligibility.
Yeah, so the eligibility for CRT is staying the same. And we tried not to change too much. What we did find with CRT programs is that through the years of serving this population, we moved more into the not habitual.
Habilitative.
Yes. Then recovery based and rehabilitative. So we are trying to move the services back to rehabilitative. And so what we have done is looked at all the services that adult mental health programs provide now, and we put them on a kind of a line, right? And so the least acute can still receive these services that are down here. And then CRT services are held for the most acute people in our system, and we kept that very similar. We had to draw a line somewhere, so it can no longer be a program. So you can't have the CRT population in a program anymore, effective 7/1. But we had to draw a line somewhere so we could say those that are above the line have a serious mental illness. And we needed to do that because couple reasons. One, we do reporting to the feds on how many serious mental ill Vermonters we have in our system. And two, we have an expansion group, so Medicaid expansion. So those that are qualified to be above the line and don't have Medicaid fall into the expansion group. So for those services, they'll have Medicaid. So we had to draw the line somewhere, but there are services, just like right now in the adult mental health world, in outpatient, they can still access some case management services if they need it, and that's still very similar. So we kept residential above the line because it really should be the most acute people in our system need community residential programs. So the threshold to receive those services above the line, which historically have been CRT, the criteria is still very similar. It's still diagnosis, it's treatment history, and it's getting to the ANSA, which is the Adults Needs and Strengths Assessment, which tells us where they're struggling, where they need help from the mental health world, where are their strengths. And so we're taking the ANSA, which is the assessment, their diagnosis, and the treatment history, and that's how we're determining that line. Does that make sense?
Yes, that's super helpful. And just a follow-up, is the way that those folks will access those various services changing? So the way they'll tap into their care manager or whatever, or, prompt receiving those services, is it the same?
It should look very similar. So they'll still need an ANSA and a psychosocial. So you'll still need that, which determines what services you need in your treatment plan, which then that case manager, therapist, whoever is working with that individual will follow that treatment plan just like now. So hopefully on the other end, they won't see too much of a change except for really, I think our CRT programs have fallen into kind of the caretaking with some folks. And really we're taking a step back from that and saying it needs to be recovery based. So how can we teach you to ride the bus instead of driving you to the grocery store every single week?
Yeah, as long as
So those kinds of things will be tweaked, but the criteria for that population will not be changing.
as long as there's somebody helping to coordinate that, because the last thing I want to see is these folks coordinating their own care.
Yes,
Absolutely.
Absolutely.
They will be driving their care, right? And our agencies will be supporting them in developing that care, but they're in the driver's seat of what care they want to receive.
Congratulations on meeting the CFCM requirements.
Yeah, it kind of was mind blowing when we first heard about it. We're like, what are you doing to us? But yeah, it's taken a lot of work. And I think from many, many, many conversations, most agencies are excited about it.
Let's be questions. Leslie and then Brian, let's be cognizant of time, and I do realize you need to leave. The good thing we gave you all this time. Leslie?
So I'm wondering, I just want to make sure I understand, moving it from, into the Medicaid state plan. Is there pressure then to get people out of the program to reduce the general fund costs?
No, that I would say no. That's never been on the table to talk about. It's always been about treatment, putting the person first. And so what does that person want and need to help in their recovery?
Okay, and can you show me where on here that is, just so I understand? I'm sorry.
Yes, that
Oh, I think I saw it right here, shared
the
living.
shared living providers, that's correct.
So
So
where
the
is
shared living provider line item is separate though from the
So
CRT
that's a zero.
conversation. In that the 8 individuals that we currently fund in a shared living program, those are moving to general fund. And so I think your question is, will there be pressure to move those folks along because they're drawing down?
Yeah, that's my
Um,
concern.
Yes, valid. At this time, we don't see that's a very small number of folks who we wouldn't disrupt their treatment.
So where's it in the general fund? Is it on, in?
It's right here. It's right here,
Very big
moving
number.
from
No.
global commitment.
Oh, I see.
It's not-
We,
Got it.
we don't, on the mental health side of things, we don't really access a lot of shared living providers, which are families. Those are someone's living in someone else's home and being paid to
Okay,
caretake.
yeah.
That's very much a Department of Disability and Independent Living program. On our side with the mental health, that's people are recovery based and they often live on their own. We have a large percentage of CRT clients that live on their own.
Yes.
So,
And that's our end goal, is that folks are living independently in our communities.
I've seen some.
Yeah, and that our communities are accepting all the folks who are a part of their community. Yeah.
Other questions?
I had a question. Is the, can you go back to the screen with the algorithm on it?
Which one?
It said there was an assessment tool, that there was an out-of-state company developing or an out-of-state
University.
or developing an algorithm.
Oh, the University of.
Yeah, thanks.
Yeah.
So this assessment tool,
Mhm.
is this an automated decision-making system?
so what we're, no, well, I'll back up and I'll explain, maybe that'll help. So, in the children's world, we use the CANS, the Children's Assessment of Needs and Strengths. And then we are looking at, and we've used I'm gonna say CANS, so I don't have to keep saying it. And so we've used the CANS for a number of years. And the ANSA, which is the adult version assessment, is what we're gonna use to help determine what are someone's needs, what are someone's strengths. UKY, University of Kentucky, is helping us to look at, we have a Vermont version that has been in play for a couple of years now. And that was developed with a few people from DMH and majority people from the designated agencies created the Vermont version of the ANSA. And so what Kentucky is doing is helping us to weigh different questions on the ANSA to help us determine where is that line and what number do we need to say this is the CRT population above the line. And so we're weighing different questions on the ANSA to help us determine that score.
So it's, this assessment tool is basically it sounds like it's not necessarily making a decision, it's a tool that's assigning numbers based on answers, but it's not necessarily saying to DMH, this person should or shouldn't get something.
No, because we're looking at the whole picture. We're looking at someone's diagnosis, someone's ANSA, and we're also looking at treatment history.
And then you just make a decision in the end based on all that. There's no machine making that decision.
Correct.
And the machine isn't learning as it goes. It's not changing the algorithm. It's like a fixed algorithm.
It's a
Okay,
fixed.
just checking.
Yeah.
And the ANSA is currently in use
Those are good questions.
right now across our
Complicated.
We
system.
really do.
What was that? I'm sorry.
The ANSA is currently in use across our system, in our current CRT programs.
Just some modification.
This is shifting it for a different purpose,
Okay, thank you.
giving it a.
I appreciate you bearing with the questions. I just have feel like we need to be paying attention to when I see algorithm now, I feel like I have to ask and understand what's.
Sure. Yeah.
You got anything else on those
Yes.
lines? Oh, my God.
These will be very quick. So the
Yeah,
next
okay.
line item, we've actually talked about quite a bit. It
Yes.
is an increase, or it's a request to partially fund a year or 1/4's worth of the alternatives to the emergency department. So currently, we're funding these with HCBS FMAP funding with a different fund source that AHS is holding. We need to shift that in the spring of 2026. So we need 1/4's worth of funding for the 4 of those. And then the rest of it is going to be moving into our facilities.
Yeah.
So section B 315, you'll see in the corner here in the gray. These are the two facilities, Vermont Psychiatric Care Hospital and the River Valley Therapeutic Residence. Again, the first section is the 38,681,170 to cover the cost of all of the salaries in fringe. With the exception of the ups, the increases for steps and cost of living. Those increases are the next 1, 2, 3, 4, 5, 6, 7 or so items. So you want this back? Salary. Oh, yeah. Yes. So the salaries, healthcare, retirement, things like that. Those items are the steps and cost of living increases for the staff at those two facilities. We also have, let's see, after the childcare contribution, we have the workers' compensation. That is an overall funding decrease, similar to what you saw in central office. Vacancy turnover savings, that's a very small amount there of an increase for vacancies savings of $8,113. Then we move into operating expenses.
May I ask a question real quickly? I just wondered, what are our current needs around travelers?
Good.
And are we budgeting for, what are we budgeting for?
Sure. So we are, there's been quite a bit of positive movement around recruitment and hiring permanent staff. And so you'll notice in our BAA, we did not have a line item to request additional funds to offset our travelers. So for this budget line item, we're continuing to hire, which is great. I think we have 9 people starting or who started on Monday. And I'll say that's one of the largest permanent hiring classes that we've had in probably 2 years at least, if not longer. So we're seeing some really great movement there. Our goal is to continue on that and that we're able to offset any vacancy savings for travelers. But our end goal is to not use travelers at all at either facility. At River Valley, they have 12 individuals who are admitted and receiving services there. They have the capacity to 16. Right now, we're not hiring additional travelers to get up to 16. We're doing sort of a 1-for-1 every time a permanent staff is hired. We let the traveler go or we shift in that way. And that's a similar approach that we're taking at VPCH. Vermont Psychiatric Care Hospital. Vermont Psychiatric Care Hospital has 4 beds that are closed, so 1 unit that is currently still closed, and they're on track to open July 1st. And we aren't anticipating that to have a budget impact.
May I ask, the large class you have beginning?
9 people.
9 people? Are any of those specialized people the result of Central Vermont Medical Center
Yeah,
closing down there?
there are a few who transitioned, maybe 2 off the top of my head, who came over from Central Vermont Medical.
Thank you.
So the next item is operating expenses that moves from.
No, I'm sorry, Shannon. I was there. She's laughing at me because I was like, you got more?
We are moving $3,306,000 again from central office to the facilities for their operating expenses. And then the next line item is the fee for space charge. That is an additional 91,613. That is across those two facilities. So some of it is for River Valley, some of it is for the psychiatric care hospital. The next line item is similar. It's an insurance, other than employee benefits, of just, that's a -$8. I know it's kind of silly to have that in there, but that's just how it works out. General liability insurance, that went down. It's a reduction of $3,967. And the rest of those line items are just there as part of the spreadsheet. There's no impact because those funds for the vision accounting system and for the Agency of Digital Services and Human Resources and such, those are all up in AHS central office section. So that's our budget presentation.
Now we're done.
Now we're done.
Now we're done.
Unless there's questions, of course.
I have one question, but I will defer to anyone else. If anyone else has any questions or.
What are you looking at me for?
No,
Oh,
I always look to you, Woody, because I know you love the lines.
you are.
You are our
Yeah,
budget.
you are our appropriations
So
person.
I expect you to ask everything. No other questions? Okay.
Welcome back.
Can you explain the difference between the shared living provider? Where you have, I think, 6 or 8 people and Dale, their shared living provider. program?
Yes, yeah, they're very similar. And part of the reason why, we don't utilize shared living providers very often because most of our folks do move on to independent living. We don't have very many folks who live with a family for long periods of time or the duration. So the shared living provider for us is a very similar model to the Dale model. And when we shifted away from the HCBS and conflict-free case management and moved the CRT services over to the state plan, we lose the authority to bill for a shared living model because it is habilitative, not rehabilitative. Does that help?
Yeah.
Okay,
Yeah, they're different levels of need.
essentially.
Yeah.
Over the long term and recovery. Long sustained need.
Thank you.
So, first of all, thank you. I always look at your budget and I always think to myself, is it enough? And I appreciate the work that you put into it and the priority services that you provide. But I can't help thinking, because it's something I'm thinking about now, there's a lot of federal funding in here.
Mhm.
And even the smallest percentage of federal funding removed. Where do we cut? What's first on the block? These are things that we need to be thinking of is, do we just do blanket cuts and say, I even think of the numbers of like 1%. What if we just had to cut 1%? Do we say everybody gets a 1% fee? Do we cut programming? Are you thinking of these things?
Yes. Yes, and nationally, everybody is
Yeah.
thinking these things. And so Vermont is in the same boat as everybody else is if there's a sudden shift. I think from our perspective, yes, we're looking at those things, what items are fully federal funded, and what items are not. And also the statutes around that funding versus the ability to just do an immediate cutoff. And so we are looking at those things. And of course, our commitment is going to continue to be services for the most vulnerable Vermonters.
So just to add on to that, is any of the moves that you made today trying to be protective or not there yet?
Protective of funding.
Our programs, yeah, is there any way we could position? And I was just wondering if you, I know you're giving it thought for sure, but I'm just wondering if in the current budget, you've done anything for it.
So this budget was developed a while ago, before sort of what's happening at the federal level now. So I'd say loosely, no,
Yeah,
but also, yes, we're always thinking strategy out, 5, 6, 7, 10 years. And so everything that we're doing builds on the previous year. And so that's why you're seeing the things that you're seeing this year without more large initiatives. We bid off a lot of initiatives in the 21 session, and those are starting to come to fruition and supporting our communities in the way that we wanted them to strategically do. And so now we're sort of moving into that next phase.
for consolidation, I guess.
If we are looking not years down the line, but if we are looking months,
Mhm.
will you have recommendations for the General Assembly
We'd have to.
to cut
Yeah,
program?
we have to make some, it's really hard to guess what's happening, but we're certainly spending a lot of time on where we think we would have the most impact in supporting our communities. So those are all things that weigh heavily. Yes, we are thinking about that. We probably would be coming back here to talk about that, just depending on what the federal landscape looks like.
Well, thank you very much.
Thank you.
Thank you.
And thanks for filling our extra time. I did want to say, unfortunately, our witnesses after we had planned were unable to make it today because of the weather.
It's supposed to get worse too.
Bridges. Yeah.
Before you leave,
It's supposed to get worse.
Thank you. Thank you so much.
Thank you.
We can go off.